Hello, everyone, and welcome to Chapter 17, where we're going to discuss the endocrine system. Now, if you watched my blood lecture, this one's going to be a little bit different from that. This one's going to be more pictures than words, so you can go ahead and follow along with the PowerPoint that I posted up there. That one's going to have a whole lot more detail written out. This is going to be mostly picture figure table based and me explaining it. I think it'll be a lot better. So to open, we're going to open with a fun fact. So one of the first scientists named Charles Edward Brown Sicard, he actually injected himself with extract from testes of dogs and guinea pigs to see what these chemicals could do on a person, right? So fun times in science. He did report an increase in strength, mental abilities, increase in appetite. So interesting first delve into endocrinology, right? Into understanding the endocrine system. Something else that doctors used to do to test for diabetes with urine, and still these tests are done with urine to test for diabetes, but back in the day, back in the early days, doctors would actually taste the urine of patients. So if the urine was sweet, there was sugar, so that person probably had diabetes, right? Really gross, really glad we are past the olden days of science. And so we're going to move on. There are four mechanisms to communicate between the cells, right? There are gap junctions, which are channels between the cells, so different substances can communicate from cell to cell. There are neurotransmitters, so these are chemicals that go from axon terminal of a neuron either to another dendrite or muscle. They carry a nerve signal, an impulse. There's the paracrines, so para means nearby, so these are hormones that go to nearby cells or tissues. They don't travel through the whole body, they just go to their neighbors. So you can remember para, nearby, easy way to link those two. And then we've got our hormones. So these are substances from endocrine glands that travel through the bloodstream to different parts of the body, and these are going to be through the whole body. So this shows some of the different endocrine organs that we have. So we have our pineal glands in the brain, the hypothalamus, which we call the master gland, the pituitary, the thyroid, the thymus, the parathyroid in the back. So parathyroid are going to be these little yellow guys right there. Ovaries or testes. You're not going to have both usually. Adrenal glands that are right on top of the kidneys, like little caps. They sit right on top of them. The pancreas, which is both endocrine and digestive. So we will talk about it a little bit in this lecture. We'll talk about it more in the digestive system lecture. And then we have, I think I went over all of them actually. So that makes up our endocrine organs that we're going to take a look at in this chapter. So there is a lot of similarity between the nervous system and the endocrine system, and we're going to learn some of these. They have different means of communication, right? So neurotransmitters are released in the nervous system. So remember synapses that are at the ends of axon terminals, they go to whatever's next, so whether it's a dendrite or a muscle, and it releases them at specific target cells, whereas the endocrine system releases hormones through the whole body, and we'll talk about that a lot. The nervous system has specific effects. Endocrine, because it's going through the whole body through a network of blood vessels, it's going to be a more widespread, more generalized effect. Nervous systems react pretty quickly, usually within milliseconds, whereas endocrine system can take up to hours, days even. The nervous system stops quickly when stimulus stops, so it has a really fast on and off response. Some of these examples are like really shooting pains they can feel in a split second and they go away in a split second, whereas the endocrine system, endocrine response to hormones is more of a slow build and a slow decline. So it's ramping up for a time and then it has to dissipate for a time. So it can be bad in the case of too much of something because you can't get rid of it very quickly, right? It's got to do a slow exit. So where a nervous system adapts really, really quickly, the endocrine system is going to be a lot more slow to respond. So it's not going to be an instant fix. This is an abbreviation chart. So some of these are abbreviated because they are way too long to say anytime that you need to say them. If you read through these, you'll notice a pattern in SH, stimulating hormone, RH, releasing hormone. You have parathyroid hormone here. Just ignore the parathormone. Nobody uses that anymore. It just stays parathyroid hormone. And you can just read through these, read through this chart. Antidiuretic hormone, corticotropin releasing hormone, erythropoietin, which we talked about in our blood lecture. We have growth hormone releasing hormone, gonadotropic releasing hormone. So don't get those two confused, right? When you see them spelled out like this, they're not very similar, but when you see the short and abbreviations, they're going to favor each other a little bit more. So I would suggest flashcards for these bad boys, but we will talk about these throughout this lecture. So the hypothalamus, many of its functions are actually carried out by the pituitary gland. So it's a delegator. The hypothalamus, it doesn't do a whole lot very directly. It delegates most of everything to the pituitary gland. So it's a funnel-shaped organ, and it's got some nerve function also, as does the part that's hanging off the hypothalamus, which is the pituitary gland right there. The pituitary gland actually hangs from the stalk called the infundibulum, but this part of the pituitary right here in the front, the anterior part, does not hang off of that same stalk, interestingly enough. So when we're looking at this, we're looking at anterior and posterior, so make sure that you are familiarizing yourself with which side you're looking at, especially when it comes to classifying it inside the brain as a whole, right? Which we will look at a cadaver brain next. So here's that stalk, the infundibulum. Here's the hypothalamus. Another look at the hypothalamus here. Pituitary gland right there, the infundibulum, which the pituitary gland hangs from, right? Okay, so remember that the hypothalamus tells everybody else what to do. And these are some hypothalamic releasing and inhibiting hormones that regulate the anterior pituitary. So we have TRH, thyrotropin releasing hormone. This hormone tells the thyroid stimulating hormone, TSH, to start. So if you're low on thyroid hormone, this is the hormone that's going to tell that thyroid stimulating hormone to start secreting thyroid, right? And same thing with prolactin, PRL. So prolactin, lactin, lactation, milk. We'll talk about that more later, but it's going to start stimulating or secreting that, right? Corticotropin releasing hormone, so promotes secretion of corticotropic hormone, ACTH, and it basically tells the ACTH to increase. So start making some more. Move on to GnRH, so gonadotropin releasing hormone. This promotes secretion of FSH, so follicle stimulating hormone, and luteinizing hormone, LH. So those have to do with the ovaries, the testes, so the gonads. So we want to increase these through FSH and LH. Then we have our GHRH, so our growth hormone releasing hormone, and it promotes the secretion of growth hormone. So don't confuse this with GnRH. And we have our prolactin inhibiting hormone. So this one stops it, right? This one turns off the secretion of prolactin. So the opposite of what we talked about first here. And then we have somatostatin, and this stops growth hormone and thyroid stimulating hormone. So it turns off growth hormone, it turns off thyroid. So on-off switches, if you guys will remember, we call these negative feedback systems, negative feedback loops. So it turns on until you get enough, and then it turns off, and then it won't turn back on until you need some more, and then again it turns off once you get enough of what you need. So we're going to move on to our pituitary hormones. So this is where the requests from the hypothalamus actually get carried out. The easiest way to remember what's in the anterior pituitary versus the posterior pituitary is that the posterior only has two. It has antidiuretic hormone and oxytocin. So if you remember that these two are part of the posterior pituitary, you're going to remember that the rest are part of the anterior pituitary instead of trying to memorize all of them. But if you would rather memorize all of them, to each his own, that's just what makes it a little bit easier for myself personally. So we only have two in the posterior pituitary. We have 6 in the anterior. So first we have follicle stimulating hormone, so ovaries and testes. And the female, it stimulates ovaries to mature the eggs and secrete estrogen. And then in males, it does create sperm. So males don't have sperm until they actually need it, whereas females are born with all of the eggs they're going to have in their lifetime. They're just immature. So this will help them to reach maturity. And there's basically a couple a month on an assembly line getting ready for ovulation. And FSH, follicle stimulating hormone, is what gets them ready. Is what prepares those eggs, right? So we move on to LH, luteinizing hormone. In females, this is what actually does cause ovulation. So it's the ripening process. It's popping the egg through the fallopian tube, the follicle the egg used to be in. It maintains that, and that's called a corpus luteum, which then makes its own hormones to help sustain a pregnancy, which we'll talk about a lot too when we talk about reproductive system and pregnancy. So luteinizing hormone, it makes you ovulate and maintains the structure of the corpus luteum. In males, it starts that testosterone secretion process, and that's basically it. So it's pretty simple in comparison to what it does for females. Moving on to thyroid stimulating hormone. So this is the growth of the thyroid, the secretion of the thyroid hormone, right? Pretty straightforward definition. And we have ACTH, which you will always hear referred to as ACTH because nobody has time to say adrenocorticotropic hormone all the time, right? So this target tissue is the adrenal cortex. It helps the structure itself grow. So ACTH helps the adrenal cortex grow, and it secretes a whole class of hormones called glucocorticoids. So we'll get into those more specifically when we get to the adrenal glands later in this presentation. Moving on to prolactin. So the target tissues for prolactin are mammary glands and this makes milk. So if you remember, lact talks about lactation, talks about milk. Prolactin makes milk synthesis in the mammary glands. And then our growth hormone, it affects so many tissues, organs. This is just liver, bone, cartilage, muscle, fat, or just a few of these. Um, it is widespread tissue growth anywhere in the body. Uh, the liver is our only one that's just going to be a little bit more unusual than the rest, because the liver itself does have regenerative properties. So that's why when folks that get liver transplants don't need the entire liver, they can only use a piece of a donor's, and it should regenerate within their own bodies as long as everything goes the way it's supposed to go, right? So moving on to our posterior pituitary, remember we only have two. We have antidiuretic hormone, ADH. So this is water retention in the kidneys. So to emphasize antidiuretic hormone a little bit, I know a lot of people have heard of water pills, so also referred to as diuretics. So diuretics make water, right? When you take these diuretics, it makes you urinate more, it makes you pee more. An antidiuretic is going to make you retain that water, it's going to make you retain the fluid, so it's not going to make you pee. What would be a good reason for this? Folks with really low blood pressure, it's going to increase their fluid, which is going to increase their pressure. So remember the blood lecture, an increase in volume and viscosity versus decrease. If your blood pressure is low, the more fluid you have, the more increased your blood pressure. So that's what antidiuretic hormone is going to do, and it's good for water retention to help that. Makes the kidneys hold on to that water instead of disposing of it. And we have oxytocin. So you may have heard of this in terms of labor and delivery. The target tissues are the uterus and the mammary glands. This causes labor contractions and milk release. The rest of these are possibly involved. Oxytocin might possibly be involved in, which are ejaculation, sperm transport, sexual affection, and mother-infant bonding. But these are just possibilities. We don't know exactly if it is or how much it is involved in the rest of those, but definitely labor contractions and milk release. So moving on to pineal gland. So don't get confused with the location of the pineal gland, right? Scroll back up to see where the hypothalamus and the pituitary gland are located, because the pineal is going to be directly above the brainstem, where the pituitary is in front of that brainstem, right? This is going to be directly above. After age 7, the pineal gland shrinks. It undergoes a process called involution, just means shrinkage. It can synchronize physiological function with 24-hour circadian rhythms of daylight and darkness. The pineal gland is involved in SAD and carbohydrate cravings. So what does all of this mean? So this means the pineal gland's figuring out your days and nights. So once you're outside of the womb. While sleeping, body systems heal and grow the best. So a lot of times doctors will put you in an induced coma so that your body has a lot of time to heal if major damage happened from any kind of accident that you may have had, really bad car wreck. Doctors will induce a coma and help your body heal. It can scare some family members, but induced comas are not going to be necessarily very bad things, because during rest your body does go through more of a healing process. So what is SAD? SAD. It is seasonal affective disorder, and this happens when days are shorter. So for us here in the Midwest, it would be the November to February range of time. Some people can go into some major depression during these times. Suicides actually also increase during times of increased darkness, which is sad to think about, but it happens. Thymus. So here are two pictures of a thymus in a newborn and the thymus in an adult. The biggest thing that you can see here is how ginormous, how huge this thymus is in the infant and how absolutely tiny it is in the adult. So as your body doesn't need something, that something is going to shrink up and we're done, right? So it has very little function in an adult. Some of its fundamental workings, those jobs that it does, is it secretes thymopoietin, thymosin, and thymulin. It stimulates the development of lymphatic organs, so it's all about getting your immune system put together. This doesn't happen until after you are born. So in babies that get breast milk, they get a lot of immunity from their mother until they can create their own immunity. And when the body's done getting the immune system put together, not really much left for the thymus to do, except some T cell activity in the adult, which we'll touch on during our immunity lecture. So the thyroid gland. So the thyroid gland secretes T4, thyroxine, and T3, triiodothyronine, which we will just call T3, in response to thyroid stimulating hormone, so THS, which came from the anterior pituitary gland, right? Which was stimulated from the hypothalamus. So to trace it back. So this increases the metabolic rate. It makes your body work a lot faster. It increases O2. It increases heat production. It makes you hungrier. It increases your growth hormone secretion. It increases your alertness. It increases your reflexes. It makes your reflexes faster. Too much T3 and T4 causes hyperthyroidism, so too much thyroid. Not enough, we call that hypothyroidism, so hypo, slow, so all of these things would slow down, so you would, get cold a lot easier, a lot faster, you're not going to be as alert. So hypothyroidism, too little. Hyperthyroidism, too much. And then we move on to parafollicular cells, so C or clear cells. These are the same, so don't get them confused. They secrete calcium. They secrete with rising blood calcium osteoblast function. So osteoblasts help build up new bone. Remember from ANP1. And this is happening pretty much when the body is building the bone. So thyroid hormone, making this bad boy is a giant process. Follicular cells are going to absorb iodine from the blood, and then it'll oxidize the ions to make them usable. So the most common way that we get iodine into our bloodstream is through iodized salt, which is why that is sold in stores. It's our main intake of iodine. If we were living in a country that ingests seaweed more often, we wouldn't need that iodized salt because seaweed has natural iodine in it. And those countries actually get iodine in their system more naturally than we do by consuming seaweed versus us consuming it in iodized salt. But hey, we don't have seaweed as readily available, especially in the area that we're living in the Midwest. So now iodine's in your blood. These cells also synthesize a large protein called TG, or thyroglobulin. So glob is your hint there that's going to be a big protein, and it stores it in the follicles. So 1 to 2 iodine are added to tyrosine within TG, within the thyroglobulin. where 2-tyrosine, whether or with their iodines, are going to meet and form either T3 or T4. So if one tyrosine links with 2 tyrosines, you have T3. If if one iodine links with 2, you get T3. If 2 iodines link with 2 other ones, you get T4. So that's how that works. Pretty simple. Pretty simple way to think about it. When a follicle receives these thyroid stimulating hormones, it absorbs the thyroglobulin and it splits the T3 or T4 off. And then the thyroglobulin can go back and redo this whole process. So it'll get recycled, which is good. Mostly, thyroid hormone is released mostly as T4 after the splitting. We're going to touch on body heat and thermoregulation just shortly because we're going to talk about this a lot more in future chapters. And we talked about thyroid gland and heat production. So this encompasses the enzymes that control our metabolism depending on an optimal stable working temperature. So to maintain this, heat loss must match heat generation. So as you lose heat, your body has to make more to replace it. Hypo slows, right? If your body temperature gets too low, if hypothermia sets in, you could die, right? It causes death. Hyper, so too high, you're overheated. Hyperthermia, overheated, you're not losing heat fast enough. So this is also fatal. So either way you cut it, both of these are fatal. So you want thermoregulation. You don't want hyperthermia, you don't want hypothermia. And thermoregulation is that balance between production of heat and loss of heat. Your normal body temperature is going to vary around 1.8 degrees Fahrenheit within a 24-hour day. It's going to be lower in the morning. It's going to be higher in the late afternoon. Core body temps are actually normally 99 to 99.7 degrees Fahrenheit when measured rectally. Rectally is going to be your most accurate. However, that is not the typical way that we do it, right? In our normal household, we'll go orally. We'll use those little strips for the forehead, under the armpit, and 98.6 is what we see when we do either of those other methods. If you are using any sort of thermometer, please always clean the thermometer that you're using, especially if you're using it rectally. But even if you're using the strips that go onto your skin or the thermometers that you would put under your tongue, always clean after use. Always clean after use. I shouldn't have to explain why. Just do it. Be clean. Moving on to parathyroid glands. So these are all about calcium. So secreting parathyroid hormone. Calcitriol synthesis is to do with vitamin D. That's coming up. We'll talk a lot more about calcitriol. With our parathyroid gland, we want to increase calcium absorption in the blood, and we want to decrease calcium excretion in the urine, so loss through pee. And we want to increase bone resorption. So if you're not getting calcium out of your diet, it will pull calcium out of your bones, which is really bad. You do not want your body to pull calcium out of your bones to use it, right? You want to be able to make sure you're getting enough in your diet so that you have stronger bones and getting the calcium you need for your parathyroid gland. And it's not pulling it out of your bones, right? So other than dairy, really, really better ways to get calcium into your diet is with dark leafy greens. So dark leafy green vegetables have better and greater sources of calcium and absorption rates, right? Well, Andrea, why do we give kids milk then? Why don't we make them eat the leafy greens? Well, that, my dear friends, is because children, until they're about 2 years of age, don't have a digestive system that's developed well enough to break down those leafy greens. So the best way to give them this source of calcium is through whole milk. We don't want to give kids skim milk. Skim milk actually has way less calcium. So even though you're getting rid of the fats associated with whole milk, you're also getting rid of the calcium. So that's why kids get whole milk. Easier for their bodies to digest and absorb calcium through whole milk. But then after the age of 2, where their digestive systems are better developed, that is when you should start, with the leafy greens, because the leafy greens do have a better absorption rate. So speaking of all of those items, calcium supplements actually don't absorb as well as you would absorb calcium through your food. But when we talk about the elderly who don't have as increased appetites, we got to give them something. So calcium supplements are the last ditch effort to get that calcium absorption into their glands. So moving on to the adrenal glands. So remember, these are our little pointy hats that sit on top of the kidney. We have our adrenal medulla and our adrenal cortex. So medulla is on the inside, the cortex is on the outside. The adrenal medulla is both endocrine and part of the sympathetic nervous system. It makes glucose, it inhibits insulin, it increases blood pressure, it increases heart rate, increases blood flow, it increases airflow to lungs, it increases metabolic rate, but it does cause a decrease in digestion and urine production. And then we have our adrenal cortex on the outside, which does a completely different thing, right? So it secretes corticosteroids, which we call hormones, corticosteroids or hormones. They regulate the body's electrolytes, so calcium, sodium, potassium, chlorine, anything I can see in Gatorade, basically, those are our electrolytes that our body needs. They regulate androgens, so male sex hormones and sex steroids. They're part of our RAA system. So our renin, angiotensin, aldosterone system, which nobody has time to say in normal speech all day long, and we just call it the RAA system. And we'll talk more about that within the kidneys. The adrenal cortex secretes cortisol, so it's involved in stress. Cortisol increases fat storage, so if you're more stressed, you're going to store fat easier, which is always awesome to learn about, right? So that's what we all like to hear. And then the adrenal cortex, they also have the anti-inflammatory effect, which is good, but it also depresses your immune system, which is bad. So more to come later on inflammation and anti-inflammatories. Moving on to the pancreas. So here in the pancreas, we have the head of the pancreas and we have the tail of the pancreas. And the head nestles itself in a small loop of small intestine coming right out of the stomach. So if the stomach were in this picture, it'd be right here. But the stomach was not added into this picture. It's just giving you pretend it's there so you can have a good visual representation of where the pancreas is located. The bile duct here that you see merges. It comes from the gallbladder and pancreas and joins together to lead to the small intestine. Here is a cross section and where you can very easily see the pancreas. However, it is very easy to, if we were dissecting a fetal pig, accidentally take out because it's very soft, it's very mushy. So for our future lab, remember not to go nuts and remove everything because you might miss the pancreas. But we'll go through that when we get closer to it. So the pancreas has both endocrine and digestive system function. We'll just discuss the endocrine for the purpose of this chapter, and we'll diverge into digestive system during our digestion lecture. All right, so you've eaten, your body's broken down the food. There's sugar in it. Now you have sugar in your blood, which we call blood glucose. Your brain tells you, hey, there's too much happening right now. We got too much blood glucose. So what happens? So the glucose goes into liver cells. Insulin converts it to glycogen, makes all of these glucoses into chains through a process called glycogenesis. So this stores your sugar. This makes glycogen because of insulin. So insulin kicks in when your blood sugar is too high. If you need more glucose, so conversely, if your blood sugar is too low, then we go through a process called glycogenolysis. This kicks in, and it takes that glycogen and it breaks it down into glucose. So glucogen is in charge here. These are very easy to get confused. So we got glucose, goes through glycogenesis, makes glycogen, and then we want to go back to glucose, it goes through glycogenolysis, right? So when we break it back down into glucose, it's through the actions of glucagon. So glucagon is in charge here. Glucagon breaks down the glycogen, which is also involved in breaking down fats and proteins to glucose. So in this case, once we go in this direction, we're making glucose. So this is a process called gluconeogenesis. So sugar, new, making. Gluconeogenesis out of fat and protein. So with glycogenesis, we're making glycogen. Glycogenolysis, we're breaking down glycogen. Gluconeogenesis, we're making new glucose. So go over this picture a couple times. You can see how I slipped up. It's very easy to slip up. So my suggestion would be to draw this out or make some flashcards. But remember the differences between glucose, glycogenesis, to glycogen, glycogenolysis, back to glucose, or gluconeogenesis, which is making glucose from fats and proteins. And how the top section is the top section is controlled by insulin, the bottom glucagon. This table is a review of everything that we've talked about. The only thing that we didn't really talk about too much are the pancreatic islets. We talked about glucagon and insulin, but something that we're going to talk about more in our digestive lecture are somatostatin with the stomach intestine, pancreatic islet cells, and gastrin in the stomach. So you can look at this chart to figure out what hormone we're talking about, what our target organs or tissues are, and then the principal effects, right? So the thyroid gland, we got T3 and T4. The target tissues are most tissues. They elevate the metabolic rate, heat production, increase respiration, heart rate, strength of your heartbeat, stimulate appetite, accelerate the breakdown of nutrients, promote alertness, quicken reflexes. So everything that we've already discussed, right? Won't go into those too much again. So other organs involved with endocrine function, we have the heart with our natriuretic peptides ANP and BNP. We'll talk about way more when we're on the heart lecture. Skin with calcitriol, so vitamin D from the sun gets converted to usable vitamin D by our skin. Kidneys, EPO, erythropoietin, renin, calcitriol. We'll go into that more with our urinary system. Liver, again, erythropoietin, EPO, angiotensin II, which is involved in blood pressure, calcitriol, vitamin D again. IGF, hepcidin. We'll look at these later in the semester. We have the stomach and the small intestine, which actually have some hormones. Leptin and the adipose tissue. So remember, adipose tissue are fat cells. Bone tissue with osteocalcin has to do with calcium storage and reabsorption. The placenta, we got estrogen, progesterone, other pregnancy hormones. There are a lot of hormones involved in living day-to-day life. So this is a good study chart as well. So I'd suggest note cards again with our source, our hormone, our target organs and tissues, and our principal effects. So we will go through these a little bit more. So with our ovaries, estradiol is a precursor to estrogen, affects a lot of tissues. Progesterone's involved in the uterus, mammary glands, menstrual cycle, and pregnancy. If your progesterone is not high enough, your pregnancy is not going to last. Inhibin from the anterior pituitary gland inhibits follicle stimulating hormone. Then we have our testes with testosterone and inhibin, same as our ovaries with the inhibin. So testes, so testosterone, musculoskeletal growth, sperm production, and libido, which is sex drive. And then the inhibin does the same thing with that it does in females, so inhibits follicle stimulating hormone secretion. In our skin, we have the precursor to calcitriol. Sorry, my dogs. Sorry about that. The dog saw a mailman. Where were we? So the skin is a precursor to calcitriol and kidney secretion. The liver has so many functions. One of the reasons people don't live if the liver fails. So you can read through all of those. Regulates plasma iron levels, prolongs and mediates action of growth hormone, promotes red blood cell production, increases oxygen carrying capacity of the blood, precursor of angiotensin 2, precursor of calcitriol, kidneys kill kidneys. Oh, I'm sorry. Yeah. No, I read it right. My bad. Continuing. Moving on to EPO, erythropoietin. So if your oxygen is low, it's going to kick in the EPO. It's a good way to remember it, little rhyme. Kidneys, we've got angiotensin 1, which is a precursor of angiotensin 2, which is a vasoconstrictor. So this increases our blood pressure, makes the vessel smaller, increases blood pressure, if you'll remember back to the blood lecture. Calcitriol we've talked about. And then we have our EPO again, erythropoietin. With our heart, we've got our natriuretic peptides, so lowers blood volume and pressure by losing sodium. So it tells the kidneys to let the salt go. So if the kidneys are letting the salt go, how are they going to do that? They're going to do that by also letting water go, right? Going to urinate it out. Our stomach and our small intestines, we have cholecystokinin, which releases bile to help break down fats in foods. We have gastrin, which stimulates acid secretion in the stomach. We have ghrelin, which is the I'm hungry signal and stimulates the hunger. A lot of new weight loss drugs try to inhibit ghrelin so that you don't feel hungry. So they try to stop ghrelin from doing its normal thing and signaling that you're hungry to curb back your appetite so you're not eating as more, which causes you to lose weight, right? Unfortunately, when you stop taking these weight loss drugs, guess what? Ghrelin's going to tell you, hey, I'm hungry. Time to eat, you know. So that's a fun fact about what we see today. We have peptide YY. Conversely, that is our I'm full signal. So it signals that you are satiated, that you're full, you don't need to eat anymore. We have our adipose tissue. So this has leptin that targets the brain. It limits appetite over the long term. It tells you, stop eating. You've eaten too much. We're starting to make fat cells. Quit it. So that's what leptin does in our adipose tissue. And then we have our placenta with estrogen, progesterone, targets many tissues of the mother and the fetus, stimulates fetal development and maternal bodily adaptations to pregnancy. It helps the mammary glands produce milk, lactation, osseous tissue, osteocalcin. Our target tissues are pancreas and adipose tissue. And it increases insulin secretion, enhances insulin sensitivity, and it reduces fat deposition. We like that part, right? So this is an example of how the endocrine system hangs out with all the systems, right? Integrated with all the systems we have. So moving on to stress and adaptation. None of us know what stress is, right? Nobody's gone through stress before. That's a joke. I think we're all very familiar with that one. Stress is defined here as a situation that upsets homeostasis and threatens one's physical or emotional well-being. So how can we trigger stress? Through injury, surgery, infection, too much exercise, through pain, through grief, through depression, through anger, through finals week, right? That always increases stress. There are several different ways to increase stress. And how does your body handle it? Through gas. That's the best way to remember it. Remember it as it gives you gas, but not in those simple terms. It's called the general adaptation syndrome. So the definition here, it's a consistent way the body reacts to stress. So typically involves elevated levels of epinephrine and glucocorticoids, especially cortisol. And we have 3 stages here. Oh, and remember glucocorticoids and epinephrine, they both deal with the adrenal glands as well. But anyways, so we have 3 stages of gas. We have alarm, we have resistance, and we have exhaustion. So alarm, that's our panic. There's something wrong, right? Our adrenaline has increased. Then, over time, we develop resistance to this. And then finally, we reach exhaustion. We are worn out from too much adrenaline, and it gets to a point where it's actually ignoring the hormone signals, and we call this adrenal fatigue. So our 3 stages of gas. All right, I told you we were going to talk about inflammation a little bit. So you guys have heard of NSAIDs, of non-steroidal anti-inflammatory drugs. So here in the first part, we are talking about SAIDs, so steroids. So steroidal anti-inflammatory drugs, right? So for example, we're talking about inhalers, steroid-based inhalers. Those will block inflammation before your body makes right here, arachidonic acid. So our SAIDs, our steroid inhalers are going to stop it before the arachidonic acid gets made. And that will convert to prostacyclin or prostaglandins. NSAIDs, so our non-steroidal anti-inflammatory drugs. Those are our aspirins, our ibuprofens. They are blocked right before prostaglandins are made. And our prostaglandins are our inflammatory markers. And they are very important. So our roles, our prostaglandin roles, include promoting inflammation. 2 cardinal signs of inflammation are fever and pain. So think short-term effects. You're twisting your ankle. There's inflammation. It causes a natural splint. That's good, right? Because we shouldn't be walking on that ankle. There should be a little bit of a cushion to sensor, hey, something's wrong, something hurts, right? However, once we have those long-term effects of inflammation, that's when it's going to be a little bit worse. These also have endocrine function, so mimics effects of TSH and ACTH. It alters sensitivity of the anterior pituitary to hypothalamic hormones. So in other words, the pituitary isn't responding well to the hypothalamus. It works with glucagon, catecholamines, so our happy hormones, and others in regulation of fat breakdown. Our prostaglandins are going to help with that. If you block that, then none of this happens, right? And we want this stuff to happen. This is the stuff that needs to happen. In our nervous system, if prostaglandins affect how your brain works and you block that, then you're blocking how your brain is normally working, right? And we don't want that to happen. In terms of reproductive prostaglandins, it helps induce contractions. So that's really important, right? Labor contractions, you want to get that baby out of there safely. In our GI system, it inhibits gastric secretion. So this stops gastric secretion. It helps keep your stomach acid from getting to be too much, from flowing out. So if your GI prostaglandins are blocked, you're going to have acid reflux because it's not inhibiting gastric secretions, right? You're going to get GERD, which is the next level of regurgitation. Not good, right? So we want inhibited gastric secretions. Vascularly, they act as vasodilators, vasoconstrictors, so dilate, open, constrict, close. Respiratory, same with bronchioles instead. So open, close the bronchioles, pathways into the lungs, passages in the lungs. In our renal system, it increases water and electrolyte secretion, so it affects blood pressure. So long-term usage of anti-inflammatories can mess with all of these over a short period of time. They can mess with all of these functions, but over a short period of time, that's not going to be so bad, right? Because sometimes it's very necessary to take anti-inflammatories. But long-term use can cause long-term effects as well. Here's a list of some disorders involved in the endocrine system. We have Addison's disease, so you guys can read through this. I'm not going to read directly from the slide to you, but this is when there's not enough happening from the adrenal cortex. So blood pressure issues, blood sugar issues, fatal dehydration, electrolyte imbalances. We have congenital hypothyroidism, so too low thyroid, and this is congenital, so you're born with it, right? So break down the words that can generally give you an idea of what's being talked about. Sometimes the thyroid gland isn't made right with congenital hypothyroidism. So these folks will always have to take a supplement of thyroid hormone. We have hyperinsulinism, so too much insulin. This can happen if you inject yourself with too much or if your pancreas is producing too much insulin. This can cause hypoglycemia, so low blood sugar. 3 S's to remember: silly, shaky, sweaty. Low blood sugar can make you really shaky, give you cold sweats, be really silly, not make any sense. Then we have myxedema. So this is adult hypothyroidism. So hypo, slow. So read through all of those. The only thing that's not going to be decreased is your blood pressure. Causes an increase in blood pressure. We have pheochromocytoma. So this is actually a tumor on the adrenal medulla that causes the secretion of too much epinephrine or norepinephrine. So these folks are in a hyperadrenaline state all the time. And then we have Graves' disease or toxic goiter. So this is when the thyroid has overgrown, secreting too much, hyperthyroid. So the thyroid thinks it's getting TSH from the pituitary when it's actually just from different antibodies. So the thyroid overgrows in response, and this causes bulging eyes as a symptom. So, so much so that the swelling can cause the eyeballs to literally pop out of the head. Couple more of hypersecretion. We have acromegaly. We have hypoparathyroidism and Cushing's syndrome. So the first one, acromegaly, causes thickening of bones and soft tissues in adults, hands, feet, and face. It's called gigantism in children. We'll see an image of that here shortly. Hyperparathyroidism is pulling calcium out of the bones, makes them more fragile, more deformed. Cushing's syndrome, too much cortisol, so also hyperglycemic, hypertensive, causes something called a buffalo hump. So upper back, lower neck area, it's a big, big fat hump, not that little C7 bone part that sticks out on you that everybody can feel if you touch it back there, but a big fat glob, a big hump on your upper back. So this is acromegaly. You can see the difference with a normal hand on the right, larger hand on the left. Or I guess if we are looking at this, the right side would be the left side, right? A little bit of anatomy for you. Cushing's syndrome. So this is the moon face. So look at the jaw, the cheeks, the chin, how it's really moon shaped and pushing out. That's Cushing's. And then we have hyposecretion disorder, so hypoparathyroidism, and this is all going to be too low. So this happens during thyroid removal surgery. And sometimes, so back in the day, the parathyroid would get removed by accident. Surgeons thought that it was part of the actual thyroid, and they were seeing the patient die a few days later. Why? Because the parathyroid was removed with the thyroid, so it doesn't really happen or shouldn't happen anymore. And then we have diabetes mellitus. So symptoms: polyuria, you pee a lot, glucose and ketones, sugar and proteins in your urine, things like that. And then we have endemic goiter. So this is really spongy. It doesn't feel like fat. It feels rubbery. It feels spongy. And that's it for our chapter 17 lecture. Here's some current topics if you want to read through those. Think about these a little bit. If you've never seen Roid Rage, it's a good video. But yeah, that's it. Let me know if you have any questions.